of business and corporate management and his noted expertise in medical physics enhance survivorship and lessen the burden of cancer. Today, he will focus on new outreach and expansion across Louisiana and into Southwest Mississippi, creating new partnerships and ushering in leading-edge technology and care. Please help me welcome Dr. Fontenot to Press Club today.
Thank you so much for that introduction, and thank you to the Press Club for the invitation to speak to you all today. This is a little bit of an update from a status report, so to speak, that this group received about 3 years ago from our prior CEO, Todd Stevens. And at the time, Mary Bird Perkins Cancer Center was undergoing a great deal of change. And the purpose of today is to provide you with a narrative of what we've been up to for the last few years, the major milestones that we've achieved, and the posture that we've taken to position us to deliver much better experiences and outcomes to cancer patients throughout the state of Louisiana and beyond. So in addition to recent progress, I'll also say a few words about our impact on cancer care across the state. This is really what our mission is focused on and what we aspire to do each and every day at the Cancer Center. And then talk a little bit about looking forward, in addition to reflecting on the last few years, what are we excited about moving forward into the near future. First, a little bit of history about Mary Bird as an organization. Mary Bird Perkins was founded right here in Baton Rouge in 1968. There was a group of community stakeholders who wanted to establish for their community a place where people could go to receive access to high-quality cancer care regardless of their ability to pay. That was the organizing principle of the organization, which started out as the Cancer Radiation and Research Foundation in 1968. It was renamed to the Mary Bird Perkins Radiation Treatment Center in 1969 to reflect the first really important commitment of resources to the cause. Local philanthropist Mr. Paul Perkins donated a piece of land, the first piece of material support for the Cancer Center, and to commemorate that gift, the organizers, the founders of the organization decided to rename the Cancer Center in honor of Mr. Perkins' late daughter, Mary Bird, hence the name Mary Bird Perkins. In 1971, we opened our doors for the first time on Airline Highway on the campus of the Old Women's Hospital, and in 1986, renamed the organization to Mary Bird Perkins Cancer Center to reflect a growing number of services that were offered in addition to radiation oncology. And you see a few photos here at the top as a couple initial founders, Dr. Jack Rathbone on the left, Miss Anna Lipsey on the right. They were one of the original founders of the organization. And a picture of the late Mary Bird Perkins is shown on the bottom of the slide here. Our mission is simple. I love to talk about our mission because it's very focused on a singular problem that afflicts most of us, either directly or adjacent to us at some point in our lifetime, and that is cancer. And we have one focus, and that's improving survivorship and lessening the burden of cancer in whatever way we can help facilitate that in the communities that we serve. And there are a number of ways that we do that. I'll talk about how we do that in just a couple of minutes. Our vision is our ambition. I believe that given the size and scale of an organization that Mary Bird has achieved, our level of focus and expertise in the area of cancer care, that we can be the recognized leader in cancer care as evidenced by our impact in cancer outcomes across the region. Whether or not a cancer patient is cared for within the four walls of a Mary Bird Perkins Cancer Center or not, I believe that Mary Bird can be and should be the tide that raises all boats, that sets the standard for what high-quality cancer care, patient experience, survivorship, and outcomes looks like. Since the last update to the Press Club in 2021, we've been focused on 3 major initiatives that constitute our goals: accelerating clinical excellence, deepening community service, and scaling our mission across an increasing number of patients and communities that we can connect our mission to. So I'll start with progress in those areas. The first is geographic growth, scaling our mission. We announced a partnership, for example, at the beginning of 2021 between Mary Bird Perkins Cancer Center and Opelousas General Hospital, one of the most underserved communities of our state in terms of cancer care, St. Landry Parish. We forged a partnership and established a presence to enhance and advance the quality of cancer care that's available in and around the Opelousas community. We're incredibly excited and proud to be a partner of Opelousas General, who is as eager as we are to partner together to bring more resources to cancer patients in St. Landry Parish and throughout the Acadiana region. Earlier this year, we announced a major expansion into Central and North Louisiana of our patient care programs and services. We partnered and integrated what had been a physician-owned oncology program that has since become new locations of Mary Bird Perkins Cancer Center. This partnership, this expansion, took effect in April 2024 and expanded our footprint significantly across the state of Louisiana. Historically, the organization had been very focused on southeast Louisiana. We had developed a significant amount of expertise, trust, confidence, strong reputation for what we could do for cancer patients and their caregivers. And really what April of this year manifested for us an opportunity to do was to leverage our confidence and experience and start delivering the programs that we feel provide the best in experience and outcomes to patients across a broader stretch of Louisiana. Many of these are in very underserved parishes and communities, which I'll get to in just a moment here. So in addition to growth, one of the ways that we have differentiated ourselves, built our brand and reputation over the years of the organization has been our investments in technology and programs. Artificial intelligence, everybody's talking about it in all sorts of different industries. Healthcare is no exception, and oncology is no exception. And my aspiration for Mary Bird is that we are always going to be on the leading edge of exploiting and leveraging new technologies and opportunities in ways that make us more effective and more efficient. And there are a few examples that we've announced just in the last 12 months of where we have utilized artificial intelligence and related technologies to help us do a range of things, from identifying the progression of cancer in imaging studies, to utilizing artificial intelligence to generate different types of information based on data that we already have about patients, to using artificial intelligence to help us schedule patient appointments more efficiently and more effectively. It seems very trivial, scheduling an appointment, but the orchestration and series of encounters that have to be coordinated for a patient once they've been diagnosed with cancer is very complex. And so using artificial intelligence to help drive efficiency and effectiveness in even menial tasks can bring a great degree of improvement to the experience that patients have once they're with us. We've also been very active in a new and growing area called theranostics. And this is really kind of a combination of diagnostic imaging, infusion therapy, where you're infusing an agent into the blood, kind of like chemotherapy, and radiation. It's the blend of all three of those interactions together to create this field called theranostics, which utilizes a lot of radiopharmaceuticals targeted to specific cancer cells. We've been the first in the area to roll out treatments and programs related to this growing area of theranostics. Pluvicto is a trade name, for example, of one that we've released and have treated about 75 patients so far with advanced prostate cancer. I would tell you there's a lot more in the pipeline coming when as it pertains to theranostics, and you can expect one of the areas of additional activity for us in the coming years to be very focused on this area. A big project for us involved an investment in what's called adaptive radiation therapy technology. And this project, we'll call it ART for short, is really a great example of what a partnership between a cancer center and its community can accomplish. This is a technology which is revolutionary. It involves the blending of real-time imaging, state-of-the-art radiation therapy, and artificial intelligence, all built into one package. The way that healthcare is reimbursed in the U.S. is such that this technology is well ahead of its ability to be reimbursed. That is to say that if we attempted to implement a technology of this based on its own business, it would be impossible for us to do that. The role of community then comes in the community's ability to see the vision of what this could accomplish, which is a transformation of how we care for patients with certain types of difficult to treat diseases. To have the trust and confidence in our ability to bring this program to fruition and then commit the resources and support needed for us to take this idea and make it a reality for the communities that we serve. So philanthropy has been a huge part of making this program feasible for us. We brought it online in December of 2023. We've treated disease sites that include prostate, kidney cancer, lung cancer, liver cancer. It's the only technology of its kind in the state, and it's enabling us to do things for cancer patients with certain diagnoses that 5 years ago would have been unthinkable. As the program has grown, so too has the reach of this program to patients outside of our community. 35% of patients treated on this system today come from outside of the Baton Rouge area to receive treatment on it. And I expect that number to increase as the visibility and awareness of this program throughout the state continues to increase. We've made a big investment in clinical trials. It's well known that Louisiana historically has been challenged in access to leading edge clinical trials. What is a clinical trial? A clinical trial is a research study that involves humans to test, in our case, new ways to treat cancer. In oncology, which is cancer care, clinical trials often involve new drugs, new surgeries, new radiation therapies, new medical devices. It's a way to provide patients with access to leading and emerging therapies sooner than they otherwise would have been able to benefit from. There are a vast array of trials that exist out there, and what's important to know is that cancer drugs must be part of a clinical trial before they can even become FDA approved for use in cancer patients across the country. So we believe, and I think, that Mary Bird, who has been active in clinical trials and research activity in the past, is the ideal partner of the National Cancer Institute, of the pharmaceutical industry, and of investigators seeking to build new and better ways to manage cancer patients. I think Mary Bird is the ideal partner to be able to connect with, to advance and develop those ideas. So one of our steps forward was to hire a physician scientist to lead our clinical trials program. He's the only oncology physician scientist in the state who's tasked with leading the specific development of a community oncology research program. It's a picture of him in the top frame here, Dr. Vic Lynn. He is a medical oncologist by his physician training and a cellular biologist for his PhD training. He is responsible for curating, leading, developing our clinical trials and research program. Dr. Lynn has been with us for probably getting close to 2 years, year and a half, 2 years. One of the goals that we had set out when Dr. Lynn arrived to lead our program was that we would unveil our phase 1 trials program. What's a phase 1 trial? A phase 1 trial is when we are testing a new cancer drug for the first time in human patients. And we're typically doing this once a cancer patient has run out of other options. All the other standard of care options have been exhausted. They're in seek of a phase 1 clinical trial to test new experimental therapeutics. We wanted to stand up our first phase 1 trial in the first couple of years. We did it in 9 or 10 months within Dr. Lynn arriving at Mary Bird. And since then, our phase 1 program, our clinical trials program, has continued to grow and to blossom. This is an important investment to make, not only because of its extension of these trials into all parts of Louisiana, but it also is creating a real value proposition for the pharmaceutical industry and the NCI to seek us out as their trials partner. There was a missive that came out from the FDA last year, focusing on the representation of minority populations in clinical trials. The average number of minority participation in clinical trials nationwide is about 5% or less. And the FDA, after summarizing, curating data that suggested that clinical trials weren't representative enough of the populations that they ultimately served, made it a mandate for trials moving forward to have a greater emphasis on minority representation. Our minority representation in clinical trials is 40%. That's because each and every patient who comes through our center is screened for a clinical trial. And so I expect the combination of our investments and our success to lead to ever more increases in the size, the number of clinical trials that we have to patients throughout the region. We've also grown the portfolio of clinical services that we offer. In its original inception, Mary Bird was focused on radiation oncology, then medical oncology, which involves chemotherapy drugs, came along. But in the last 3 years, we've also gotten more active. We have oncologic surgeons on our staff, geneticists, palliative medicine, supportive medicine physicians, navigators, nutritionists, social workers. If you were to check in on the size of our active medical staff 3 to 4 years ago, you'd find the size of a medical staff that had probably 12 or 14 active providers on it. Today, that number is almost 70. So we're growing substantially the areas of expertise that are a part of Mary Bird Perkins Cancer Center. Community outreach, community service continues to be an important part of our organization. That's why we were founded, to be a resource for the communities that we serve. One of the programs that we facilitate this service through is our Prevention on the Go program. It's established in 2002, covers 33 parishes in Louisiana, 4 counties in Mississippi, and is focused on providing education, early detection services in locations where people live, work, and worship. It's taking preventative services and awareness to where people live. One of the backbones of doing that is through a series of mobile medical clinics. We have 3 today. We've got a 4th on order that provides specialized capabilities that enable our prevention team to go out to these communities and provide free cancer screenings in these communities where people live and work. To date, more than 115,000 screenings have been provided across Louisiana. This will be a little bit hard to see, but I want to call out this because of the significance of the types of populations that we're reaching. About half of the participants that we screen, have no insurance. We're a Medicaid expansion state. This number should be quite low. 50% of the patients that we screen have no insurance. 65% of them don't have a primary care physician. Think about that. That means in many of these encounters, for many of these screening events, this screening encounter will be the only healthcare encounter that these participants will have during a given year. And what underlies this prevention program is a navigation program that then will connect patients who have abnormal findings to the next step of care. It's not enough to say you've got an abnormal finding. You need to have this followed up. We have the team and support in place to be able to connect that patient to the next step in their care process so that they can follow up on their abnormal finding. We're very active in community education as well. We host a number of events in Baton Rouge, throughout the region, throughout the state. Many of these programs, these education and outreach programs, have become funded by community grantors. And just in the last 12 to 18 months, multi-million-dollar grants from the United Health Foundation, from the Merck Foundation, focusing on extending and supporting our outreach and awareness programs to underserved populations across urban and rural areas. There will be more of this to come in the next few years, and we are building, I think, a network and infrastructure of resources, information, and connections to be able to support as many patients across the state as we can possibly reach. Now, a few words on the impact on cancer care in Louisiana. This is really why we do this. Louisiana has the 5th highest cancer incidence in the country and the 10th highest mortality rate in the country. So mortality rate being how many people die from cancer. We're on the wrong end of the scale in both of those metrics. And what this graph is showing is where survival rates are the worst across the state of Louisiana. And the blue shaded parishes are where cancer survival is worst in the state of Louisiana. Not surprisingly, the further that you move away from population centers, the worse cancer outcomes become. We know that the longer, the harder, the farther that patients have to go and work to access care, the less likely they are to pursue it. And within these populations, within these areas, we have many patients throughout the region that we serve whose cancer diagnosis is not their biggest problem. So creating a network and infrastructure of support to help tackle these cancer survivorship issues is really what we're ultra focused on. And we're focused on it through becoming Louisiana's largest cancer care organization. This map shows our present locations across the state of Louisiana. And I would submit to you that if you were to overlay this map with the cancer survivorship map from the previous slide, we are well positioned in a number of rural and underserved areas to provide better access to high quality cancer care. And we do that through our growing provider network, our increasing geographic reach, and the larger number of patients who we're reaching through our programs. We're also significant advocates for cancer care policy. We're involved in a number of legislative initiatives focused on cancer care and policy making throughout the state. We also have a number of partnerships with LDH to help support our outreach and screening programs across the state. This will be another graph that's a little bit hard to see, but I mentioned patient census and impact before. In the last update to the Press Club in 2021, Mary Bird Perkins Cancer Center was managing about 2,000 unique patients on an annual basis. Last year, that number was 25,000. Halfway through 2024, we're already at about 25,000. So our reach in terms of the number of cancer patients, both new and existing, across the state and the region is accelerating. We expect in the next 12 months to manage about 7,000 newly diagnosed cancer patients. That accounts for about 25% of all newly diagnosed cancer patients in the state of Louisiana. Partners are essential, vital to us. One of the things that Mary Bird Perkins Cancer Center is not, we're not a hospital. We're an outpatient diagnostic and treatment facility, owned by the community, supported by the community, but one that's also in need of having strong partnerships with like-minded community organizations throughout the state. Our partnership with Baton Rouge General is critical. It's an important partnership for us here in the greater Baton Rouge area. Allows us to keep accelerating and differentiating our unique cancer programs that we can then scale out to communities across the state. We have partnerships with Terrebonne General, Women's Hospital. A number of years ago when our collaboration, our partnership with OneOncology was announced, that's a great resource that helps us get access to high quality drugs, access infrastructure, support, and resources that we would be challenged to develop on our own. So partnerships have been historically an essential part of our growth and success, and will continue to be a very important part of our strategy moving forward. So moving forward, what are some of our future plans and goals? Our pillars are going to stay the same. It's what I think the organization has been created, established, and empowered to do. Accelerating clinical excellence, advancing technologies. There will be more technologies to come. Oncology is an innately innovation-leading specialty in industry. So whether it's drugs, whether it's artificial intelligence, whether it's the latest hardware, we're going to be positioned to be the forefront of bringing those to the community and making them available to our physicians and their patients. Mary Bird is building the leading clinical trials program in the state. And I believe that. I believe in what we have. I'm proud of what the team has accomplished, and I'm even more excited about what they will accomplish. Not only because of the acuity of the portfolios that they're building in general, but the accessibility to it from communities and locations across the state. I'm really excited about that moving forward with our trials program. Deepening our community service is going to continue to be a focus of ours. We are gaining momentum in our support from community grantors as they recognize that the value that we can provide in deploying those resources to improve survivorship, lessen the burden, I think are only going to foster additional opportunities for us of a similar nature. And scaling the mission, I think, I was just talking about this before the luncheon here. With every organization, there are times of change, and there are times of kind of continuity. And I think we're still very much in a position of evolving as an organization, not only geographically in terms of our growth, but programmatically in terms of what we aspire to provide our patients once they get connected to us. So scaling the mission continues to be one of our important priorities. How you can help us. I've said it a couple of times, we are community-supported, community-owned organization, individual giving, corporate giving and sponsorships, volunteerism within our cancer center locations. You can attend one of our outreach events. We do numerous outreach and screening events throughout the year, both here in Baton Rouge area and elsewhere statewide. That's a great opportunity to connect and see for yourself the impact that we're having in the communities that we're in. Ultimately, this is all about helping to share our story and helping to foster an understanding of what Mary Bird is, why it's here, why what we do is important, and why what we do is worth supporting. So I'll thank you for your time, and I'll hold for questions. So the question was related to our outreach program that provides free screenings to people throughout the community, and about half of those people that we screen have no insurance. How do we support them to the next step of their care? There's a few different ways that we do that. We have the ability to enroll patients on Medicaid. So if we find that they have a problem and that they need to have it followed up on, trying to get them set up with a Medicaid plan is one piece of how we help connect them to the next step. We do participate and receive funding from the state, philanthropy, other sources to help connect those patients to the next step in the process. So for example, if a patient in the Delta region, south of Monroe, has an abnormal FIT kit, which is testing for colorectal cancer, we will get the result of that test, and then we have in place a contract set up with a local GI provider that is funded through either that interaction is funded through Medicaid or through a state contract, et cetera, to be able to have that patient have a place to go and get the follow-up care that they need. So there's not just one answer to the question, it's a combination of resources that we draw from to support those patients who are uninsured and that need support, social, financial, etc., to accessing the next step of care in their diagnosis or potential diagnosis.
Follow up to that, but these places with extreme poverty, are there any healthcare facilities for doctors nearby? Where these people are in a desert?
Yeah, so the question was about the accessibility of healthcare in general, I think, in some of these rural communities. Absolutely a problem. It's 100% a problem, and it's still a problem today. Our expansion into some of these communities gives us a base to be able to connect them to. And we know that we can deploy telemedicine. That's a virtual health visit. That's one possible way to connect a patient to a provider if they're in a remote area, assuming they have the bandwidth, the network coverage, and IT infrastructure to be able to make that connection. We can use what's called extenders. These are nurse practitioners or physician's assistants that can operate a satellite clinic to help connect a patient to the services and resources that they need. Ultimately, it comes down to proximity. As I mentioned before, particularly many of these rural and underserved areas, the burden of accessing care can be significant. And the longer and the harder they have to work to access that care, the less likely they are to embrace it. So proximity is important. There's a lot of rural hospitals, rural health clinics that exist out there. And so one of our strategies right now involves collaborations with some of those rural hospitals and health clinics to be able to offer an oncology service that is maybe not there 5 days a week, but maybe it's accessible once a week, remotely on the other days, to be able to at least provide this patient with some local resource or connection that they can utilize to follow up on whatever their condition is. Yes?
I'm trying to budget funds for Medicaid, and are the Medicaid recipients, do you break even?
So the question was about our payer mix and whether caring for Medicaid patients is economically productive or economically challenging to the cancer center. That's what I heard. So let's talk about our payer mix first. Cancer in general is a Medicare-aged diagnosis in general. There's exceptions, obviously, but about 60% of our patients are Medicare eligible, Medicare. And about half of those are in traditional Medicare, half of those are in Medicare Advantage plans. There's another, depending on the parish that we're talking about, 10 to 15% of our patient population that is on a Medicaid plan. The remainder is commercial insurance. That 10 to 15% Medicaid is challenging for us. The state government, the federal government have resources to help healthcare providers take care of Medicaid patients. The problem for us is that we're not eligible to participate in any of those because we're not a hospital. So we're not eligible for directed payments from the state. We're not eligible to participate in the cooperative endeavor agreement that many hospitals around the state participate in to fund their care of Medicaid patients. We're not eligible for the federal drug discount program because we're not a hospital. So for us, managing, caring for Medicaid patients is economically challenging, substantially so. We do it because it's part of our mission, part of why we're organized, and part of what we are here to do. And so our remedy to not having access to those resources is to access as many levers as possible. Grant funding, the resources that do exist. LDH has been a good partner of ours in helping to try to find ways creatively to be able to support our work within these communities and with patients under the managed Medicaid programs. There's no silver bullet. If all we had to try to take care of was Medicaid patients, that'd be really difficult, but fortunately we have enough of a balance across our patient population and where we get funding from to make it work. Thank you for that question. Yes?
Let me take the picture first. Oh. What? And you're talking, sometimes I can't hear. Is all 100% of y'all clinical research, is it done in-house? Or you got some other research that are done with other organizations?
So, yeah, that's a good question. The question was about if our clinical research program is done internal to Mary Bird or if it's shared with or across other organizations. Our clinical research activities and program is completely funded by Mary Bird Perkins Cancer Center and exists inside of the organization. That said, we collaborate just about every day with patients who are coming from other healthcare organizations who would like to access our clinical trials portfolio. So, and access the trial that we have that may not be available to them wherever they're receiving their cancer care. And so my philosophy on our clinical research program is that it should be an open door to anybody who would like access to it, whether that patient, their caregiver, their physician lives inside of our organization or outside of it.
Y'all affiliated with certain hospitals, and I know y'all went through the last 3 years. In fact, y'all the same deal. This is the story of, I'm a cancer patient. My doctor's in bladder cancer, prostate cancer. I do a lot of fundraising for Tulane, prostrate, breathe that. They got gun shooting. So I work with a lot of them. But if my doctor, whose office is in Lady Lake, y'all no longer affiliated with the Lady Lake at all, right?
So what I would say about our partnership with Our Lady of the Lake is that it has changed from where it was 5 years ago. It's certainly much less formal than it was, and we had an affiliation agreement, Mary Bird and Our Lady of the Lake did, that ended at the end of 2021. That, I would say, did not mean the end of our collaboration. And there are many other programs and areas that Mary Bird and the Lake collaborate on. We're in each other's backyard. It is inevitable that we're going to collaborate and remain partners in the coordination of care for patients that we share, and still to this day with specific programs that we share in together. So the nature of our partnership and relationship with the Lake has changed, but it is not dissolved or ended. And in fact, I'd love to see it continue to evolve and find itself into a place that is mutually beneficial for the support of everybody in the community.
Y'all have made so much advance, you know, wherever everybody back in the day, they want to go to MD Anderson going up on the East Coast. And so, God bless y'all. Moving everything here at central location. I didn't realize y'all were all over the state, which is the Senate. So, God bless.
Yeah,
That's my question. Thank you.
Yeah, thank you for that. And look, MD Anderson's a great place. I spent 6-7 years there training. That's where I trained. It's an amazing place. It's a wonderful place. They can do some things there that really nobody else in the world can do. But I would tell you that the percentage of cancer patients for whom that's really important is comparatively small. Most of what many cancer patients need can be furnished and provided in the communities that they live. And Baton Rouge is no exception. You can get great cancer care here. And to be able to do that within a community, staying in your home, maintaining your relationships, your support network with your friends and family, that adds a lot to the outcome and journey that cancer patients have to navigate during their diagnosis. Yes, ma'am.
Are you seeing greater improvement in the remission of cancer care? I'm sorry, remission of lung cancer care?
Yeah, so lung cancer rates is really interesting if you look at the curve of smoking rates in the United States over time and overlay that with lung cancer incidence rates. The peak of smoking utilization in the U.S. occurred, I don't know, sometime in the 80s. And the incidence of lung cancer, its growth, its peak, and now its decline offsets that smoking curve by about 15 to 20 years. It's, you know, and coming from a background of research and science, you're always a little bit hesitant to say that one thing caused the other. But certainly there's a very strong connection between those two trends. And so, yes, we have seen cases of lung cancer in decline for the last few years. The challenge with lung cancer, though, is that it's pretty deadly in many cases once you get it, particularly if it presents, like most cancers, in its later stages. So the mortality rate, that is the percent of people who die from lung cancer, is quite high still compared to other types of cancer, which is why it's so essential for people who have risk factors, who have smoked, who have been exposed to certain environmental conditions, to follow their lung cancer screening guidelines and get screened. Because lung cancer, like most others, if it's detected early, is much easier to manage than if it's uncovered later. Thank you. Thank you.
Did a good job. I don't know what to bring back to that. Y'all got a walking report?